So the most important thing that a guy can do before cancer treatment is, number one, see a fertility specialist so that we can get an idea about what we really have to work with before he even goes through treatment. Some guys have certain types of testicular tumors that already cause their sperm to be very abnormal. And so we may very well already, even before treatment, have a low sperm count, low sperm volume, poor motility, or a high concentration of abnormally shaped sperm. So the first most important thing he can do is come see a fertility specialist and let us get a good handle on what's going on and what we have to work with. So let's assume, for argument's sake, that the guy's got pretty reasonable sperm. If he does, we would encourage him to bank as many specimens as we can get before he actually starts treatment. The optimal way to do this is to have him collect a sperm specimen for us every other day, really for as long as he has before he starts treatment. And that allows us to freeze multiple vials out of each specimen that we get. Even if guys have really poor sperm counts, they've got really low sperm counts, we can still encourage them to try and bank some sperm because, again, that may be all the sperm that they have. Because a lot of the times the agents that the oncologists give for treatment of testicular cancer, lymphoma, leukemia, render guys completely sterile. The question really is, what can guys do after treatment to determine whether they're fertile or not? And the most important thing they can do is they can come see us and let us do a semen analysis. We need to assess what we have to work with now after treatment. But the other thing that's really important is the guy's got to know what he took. He's got to know how he was treated, because there's a lot of different types of cancer chemotherapeutic agents and they all work differently. Some of them can really wipe out the entire sperm count. Some of them may alter the DNA in the sperm itself. So we really need to know how the guy was treated. That's probably going to prompt us to call his oncologist. We'll have a conversation with the oncologist himself or herself to find out what they think. Because sometimes, even if a guy's got sperm after treatment, they may recommend that we wait for a certain period of time to make sure that the sperm that were potentially exposed to treatment are gone, make sure they've all died off, or make sure they were ejaculated. Sometime they may actually say to us, and I've had this conversation with oncologists before, you know, even though he's got some sperm there, it's probably best not to use those. Let's use the sperm that he banked before treatment, because that way we know those sperm were totally unaffected. And so we'll have this conversation with the couple or with the guy as well. Now, what if the guy has no sperm? We go ahead and we do a semen analysis and he really has very little, if any, sperm there. Donor sperm is a great option. It works really, really well. It's very effective for fertility. And there's so many different types of donors that we can easily match this guy, pretty much any guy, by race, blood type, height, weight, hair color, and eye color, so that they'll be able to find a donor that really, truly resembles them. So after treatment, we need to find out really what we have to work with. So some guys after treatment are going to have no sperm whatsoever, and their only real option is to explore donor sperm. Some guys may have really low sperm counts, and some guys may have really pretty normal semen analyses. And that depends on so many different things. Depends on what kind of cancer they had, how they were treated, the drugs they were given, if they were given radiation therapy, if a testicle was removed, obviously if both testicles were removed. So it really depends on every individual. Every cycle is different, every guy is different, every treatment is different. So let's assume, for argument's sake, that the guy's got a lot of good sperm left. Well, intercourse may be a great option for him. He may not need any fertility intervention at all. He may just need some counseling. We may need to walk him through what happened, what he has left to work with, and the best ways to optimize natural fertility. Let's assume, for argument's sake, that he's got a pretty good semen analysis, but there's still some significant impairment. Well, IUI, or intrauterine insemination, may be a really viable option. So what we can do is we can take his partner, and she can either use an ovulation prediction kit, and we can, the day after she has her LH surge, so in other words, when she's ready to ovulate, we can get his sperm, wash it, spin it down, separate the good sperm from the debris and the dead sperm, and put that good sperm sample into his partner's uterus. Depending upon how we're treating her, if it's a natural cycle, if she's on some fertility pills, if she's on fertility injections, that changes the chance for pregnancy. So in a natural cycle with intrauterine insemination, he can expect a chance for pregnancy of maybe 6 to 10% per cycle. And the risk of multiple pregnancy is no greater than nature. Now let's assume, for argument's sake, that the woman's on fertility pills. The chance for pregnancy goes up a little bit, say maybe 10 to 15% per cycle, but the risk of multiple pregnancy goes up also to about 5 to 8%. Fortunately, almost all of those pregnancies with fertility pills are twins. Rarely, if ever, are there triplets or more. Now the next option is she can go on fertility injections. And if she takes fertility injections, her chance for pregnancy goes way up. It goes up to 20, 25, maybe as high as 30% per cycle. But the risk of multiple pregnancy goes up to 20%. And unfortunately, not all of those are twins. There's a rare case of triplets or more. And that's why we monitor these couples very closely when they're going through stimulation, so we can make sure that if they've got too many follicles and it's too dangerous, we cancel them before even we make them ovulate. Now let's assume for argument's sake that he's got a really low sperm count. In that case, in vitro fertilization, or the test tube baby procedure, may be their only real option. So what happens then is we stimulate the woman's ovaries with injectable fertility drugs. We monitor her during the course of her treatment. When her eggs are mature, we take her to the operating room for a non-surgical, no incision procedure where we can vaginally, using ultrasound guidance, pass a needle through the top of the vagina into the ovaries to get the eggs out. We take the eggs into the laboratory, and then we can add the guy's sperm to those eggs. Depending upon the quality of his sperm determines how we handle the sperm. So if he's got a moderate number of sperm, say 10 million moving sperm, say even 5 million moving sperm, we may very well be able to add sperm to a microscopic droplet of fluid that contains each egg. And that's basic in vitro fertilization. Now let's assume that he's got a really low sperm count. His testicle was removed, he had intensive chemotherapy, he had radiation after chemotherapy. In that case, his sperm count may be severely depleted, and what we may have to do is what's called ICSI, or intracytoplasmic sperm injection, where we can actually pick up a single sperm with a microscopic needle and inject that sperm directly into his partner's egg. Very effective procedure. The chance for fertilization is about 75% per egg that we inject, which is really about the same as when we do in vitro fertilization without ICSI. The risk of problems after ICSI appears to be no greater, so those babies have the same chance of pregnancy, same chance of being born, same low chance of having birth defects or other problems as babies that were conceived through in vitro fertilization without ICSI.